Hello, hello. Can you hear me here now? I mean, on the system.
Good morning, everyone, and welcome to this week's Clinico-Pathological conference hosted by Upper GI Surgical Department. Sorry for the delay, and let's get straight into it. Today, our chairperson is Professor Dato Dr. Nick Rizakosai, and I'll be your moderator today. My name is Anitha, and our discussion today is titled Between the Devil and the Deep Blue Sea, a Diagnostic Conundrum of Dual Pathology. So we'll just get straight into it. I'd like to call upon our first speaker, Dr. Guhan Muthkumaran, to present the history.
Hi, very good morning to everyone. Thank you, Dr. Anitha, for the introduction. Yeah, so we have an unfortunate case here. This was a young girl. Generally speaking, I think when we do present our cases, they tend to have happy endings, but unfortunately in this one, spoiler alert, the outcome was not ideal. So with that, I would like to begin. So the presentation is a Clinico-Pathological conference this morning is Between the Devil and the Deep Blue Sea. So we have a young lady who presented to us, a 32-year-old UNHCR refugee who's been living with us for the past 1 decade. She presented with a fairly short history, actually, of abdominal symptoms. Initially, she presented with pain for 2 days, and in the past surgery, in the presenting history, the pain was generalized, however, predominantly on the right side. They've been progressively worsening. She also had bouts of vomiting for the last 3 days, and she was unable to tolerate orally, nor was she actually passing motion for 2 days. So relevant negatives in this patient, number one, she did not have any fever, aperitic. She had previously had normal bowel motions, once a day, soft sleeps. No bleeding, no constitutional symptoms, nor did she have TB symptoms to suggest, for example, fever, night sweats, nor did she have any TB contact. And there was no remarkable systematic review history. So past medical history and surgical history, there was nothing of great significance either. She only had one emergency cesarean section in 2013. Otherwise, in her drug history, we are not sure whether she had had her BCG vaccination in the past. And otherwise, she has not been taking any traditional medicine, and she did not have any food or drug allergies. In her family history, again, she denies any history of cancers or any sort of chronic illnesses. A little bit of menstrual history. She attained menarche at the age of 14. She had regular menses, mild dysmenorrhea on and off, blessed with 2 children. First one was SVD, the second one was a cesarean section. And at the moment of presentation, she did not have any conception. Social history, unfortunately, she does come from a slightly lower socioeconomic status background. She herself is a homemaker, and the husband is the sole breadwinner who works as a laborer. She lives in a crowded flat with multiple other refugees living together with them, denies any alcohol abuse, and also denies any recreational drug consumption. So when we saw her, she was dehydrated. Patient was complaining of pain. She was of slender build, but she was pink and not jaundiced. Her vitals were fairly stable, afebrile, and not tachycardic. Abdominal findings, clinically, when we actually saw the abdomen, it was slightly distended. There was a phalangeal scar, which was healed, and the abdomen was distended with tenderness, more towards the right side of the abdomen. There were no hernias to be seen. A rectal examination found to have an empty collapsed rectum. Otherwise, there were no lymphadenopathy to be found, no organomegaly either. So at this point, at this juncture, our working diagnosis for this patient was some form of perforated viscous, intestinal obstruction, pancreatitis, possibility of appendicitis, or even a ruptured ectopic pregnancy. So these are her lab investigations that we have provided here on this table. I will summarize it. They are normal. So this is an X-ray that we took for this patient when she presented. We have a chest X-ray on the left and an abdominal X-ray on the right, both of which are fairly normal. On the left, the lung fields are normal. The cardiac borders are also fairly normal. And below the diaphragm, there's no evidence of air under the diaphragm. On the supine abdominal X-ray again, we see some prominent bowels. However, there's no evidence to suggest pneumoperitoneum. So I will hand it over to you, Dr. Emilia, to discuss a little bit regarding the CT scan.
Our next speaker is Dr. Emilia Rosniza from the Radiology Department in HCTM. Please proceed.
Thank you, Dr. Anitha and Dr. Guhan. Okay, I am Emilia, radiologist here in HCTM. I'll be presenting on the CT scan of this patient. Okay, so the striking features is the centrally located dilated small bowels, okay, which measures more than 3 centimeter in caliber. So you can see the presence of valvular conniventis within these bowels, indicating it's a small bowel dilatation. Okay, so it's a small bowel, centrally located, dilated more than 3 centimeter. And when you see this small bowel obstruction, you need to look for the transitional zone, which is the abrupt change in the caliber of the small bowel, as well as the secondary sign of small bowel obstruction, which is called the small bowel feces sign. So the causes of small bowel obstruction can be divided into mechanical and functional cause. And in mechanical obstruction, there are a list of causes, which include infection, inflammation, neoplasm, mass, adhesion, intersusception, and the list goes on. So the provisional diagnosis actually differs depending on the clinical, radiological, and the age of the patient. So we go back to the CT scan of this patient. So here in the axial scan of the CT, you see a circumferential wall thickening of the terminal ileum. And when I zoom in, you can see it better. So on the left-hand side or right-hand side, okay, that's the distal ileum. the terminal ileum, and the cecum. So you can see the circumferential thickening of the terminal ileum. So again, in coronal view, presence of circumferential thickening of the terminal ileum. The cecum is normal in caliber and not dilated. So there is abrupt change in the caliber of the bowel. Okay, small bowel feces sign, it means the presence of feces within the small bowel. So this occurs during obstruction, gradually obstructing bowel. So on the red arrow is showing the distal ileum, presence of feces within, and on the yellow arrow is actually pointing towards the cecum. Okay, and then when I scrutinize the image further, what I see is that there is an incentric thickening of the gastric lesser curvature of the stomach at the gastric antrum here, shown by the yellow arrow, as well as multiple circumferential wall thickening of the small bowel, which is shown in the red arrow. So again, in a coronal view, the yellow arrow is pointing towards the eccentric thickening of the gastric antrum, and the red arrow is pointing to the abnormal mild circumferential thickening of the small bowel here, multiple areas. Okay, there is a presence of sub-centimeter right iliac node, sub-centimeter, less than 1 centimeter, and no necrosis, which could represent, is typically seen in tuberculosis. So overall findings, okay, we have a circumferential wall thickening of the terminal ileum that is causing small bowel obstruction. We have secondary sign of small bowel feces sign. There is a focal eccentric gastric antrum wall thickening, as well as multiple mild small bowel wall thickenings, which could represent escape lesions. So the differential diagnosis at this point of time in a young patient, 37 years old with abdominal pain and vomiting, is most commonly as inflammatory bowel disease, the Crohn's disease, and infection, TB ileitis, but there's no necrotic nodes seen. And lastly, malignancy, although this will be down the list depending on the patient's age and the multiplicity of these skip lesions. Thank you.
Thank you.
Guhan, you have the
Dr.
floor
Anitha.
now.
Thank you, Dr. Anitha. So yeah, so I'm going to so after looking at that CT scan, a decision was made for us to take this young lady to theater, and she underwent surgery, and she had a limited right hemicolectomy. There was also a resection of small bowel and a double barrel stoma. There was a transition zone, as mentioned, in the terminal ileum. It was thickened with multiple lymph nodes seen. The proximal small bowel was edematous and dilated. The mesentery of the small bowel towards the terminal ileum was also unhealthy and easily tore during our dissection. So we had to resect that disease segment of the small bowel. So here are images we have taken intraoperatively of this lady. And a little bit, as you can see, the arrow pointing in this image shows the transition zone of the small bowel. Everything beyond that is collapsed, and everything proximal to that is distended and dilated. So this is the image of the specimen grossly, limited right hemicolectomy. So you can see the cecum, which is labeled there on the top right, and the small bowel towards the left-hand side of the image. And this is the image itself that has been laid open of the specimen. As you can see, the bowel itself is narrowed. However, the mucosa appears normal in the specimen. So this was actually sort of like something for us to actually look into. And I think later Dr. Farhan will update us a little bit on what we actually found. So this is the segment of small bowel that was resected. As you can see, it's edematous, it's dilated, and the mesentery is unhealthy There's numerous lymph nodes seen along it. They're small nodes, but they were all over the entire length of the small bowel mesentery. So I'll hand it over to you, Dr. Farhan.
Next, we have Dr. Farhan Ibrahim from the Pathology Department at HCTM. Please proceed.
Welcome and good morning, everyone. So I'll be presenting for the histopathological finding for this case. So the first section we received, the first specimen that we received is the right hemically specimen. And in this section, we can see that the main bulk of the tumor is located over the serosal area over here. And the tumor is infiltrating through the muscle layer, going into the mucosal surface and causing this ulceration. Under higher power, it is important to know a little bit about the morphology of the tumor, because it might give us an idea on where it came from later on. So over here, we can see that they are arranged in tubular formation. Some are having this signet ring-like appearance, such as over here, and they are cohesive. Again, over here on the surface, we can see that this is the area of the ulceration, and there's no dysplasia to the surrounding of the at the site of the ulceration. Usually, if the tumor arises from the site itself, we will see presence of like normal mucosa followed by dysplasia, and then the presence of the tumor. But that's not in this case now. And from the mesentery, we can see presence of a tumor nodule which has similar morphological features as mentioned before. Again, specimen B is a small bowel. We can see that the muscle layer of the epithelium and the main bulk of the tumor is located over the serosal area. It is infiltrating into the muscle layer. However, the mucosa looks normal. There's no dysplasia. Again, mesenteric nodule shows presence of tumor nodule which has similar morphological feature as mentioned before. And then we did CK7 and CK20 to point us out on where the origin of the tumor might be. So in this case, the CK7 is strongly positive, while the CK20 is mildly positive. So this gives us an idea that it could be a very diaphragmatic area, for example, like the stomach, biliary tree, or even the pancreas. Specimen C received with the mesenteric lymph node, in which we see in this section presence of macrogranuloma with presence of necrosis, like in giant cells, which might suggest presence of which is commonly seen in cases of tuberculosis. So, in correlating with the histopathological finding, in which we see presence of multiple foci of adenocarcinoma involving the mesentery, and it has the signet ring-like appearance, and then there's no mucosal dysplasia, and then our immunohistochemistry might suggest the site that this tumor may be rising from stomach. And second one is the chronic granulomatous lymphadenopathy. Due to presence of presenting macrogranulomas within the lymph node, this may raise suspicion for concomitant tuberculosis. That's all.
Dr. Guhan, please continue.
Thank you, Dr. Anitha.
We'll be talking about how the case was subsequently managed. Dr. Guhan will have the floor.
So this was almost 3 weeks after surgery. She needed time to recover, and she had slight amount of high output stoma that we had to settle down for. So by the time we had the pathological specimens and the patient had settled down, it was already in the 3rd week of April that we got things sorted for her. So we had a multidisciplinary team meeting at this point. So we had the oncology team, the surgical team, the respiratory team, pathology, and radiology together to actually plan a direction of care for this lady. So the initial diagnosis we have come up with at this time was the gastric adenocarcinoma, which is metastatic in nature, and extrapulmonary tuberculosis. So the cancer, as mentioned by Dr. Farhan, was of the signet ring type, which unfortunately carries a poor prognosis. And of the lymph nodes that we removed during our surgery, of 39, 6 of them were positive for granulomatous lesions. So the consensus was number one, endoscopic management, and number two, endoscopic viewing of the bowel, including the colon and the stomach, and followed by a PET CT scan to actually assess radiologically the rest of the patient to actually decide how we're going to proceed. So treatment strategies, on the other hand, we were planning to actually start her on anti-TB for 4 weeks, and then subsequently to initiate palliative chemotherapy for her after initiation of anti-TB. So she was started on a tablet Accurate, which is a combination of 4 anti-TB medication, and also we performed the endoscopic images, and we found that she had a tumor, an ulcerating tumor, which was classified as a Bormann type 3, which again, the histopathology was similar to that of the metastatic tumor that were found in the bowel. And the colonoscopy, we only found the polyps that were not malignant in nature. So this is the endoscopic image, and you see on the left are the OGDS. So those of this, and you can see on the 6 o'clock of this image, you can see an ulcerating lesion, which is rather small actually. This lesion's biopsy has come back as also signet cell, which is correlating, as mentioned earlier. On the right-hand side of the image are the colonoscopic images. So these were polyps that were seen in the colon, and of these, they were not malignant in nature. So staging studies that we did for this patient. So the CT scan did not show lung metastasis. The PET showed diffuse hypermetabolic regions in the stomach, antrum of the stomach, and the pyloric region, and also diffuse uptake in the small bowel. This diffuse uptake correlates with what we actually saw intraoperatively, which was multiple tumor deposits along the small bowel. And a repeat CT scan a month down the road now showed that she had progressed, unfortunately, in her cancer with complex ascites and streakiness, which suggested peritoneal metastasis. So as mentioned before, so these are the images that we were taken earlier, and based on this, our diagnosis, as I already I'm reiterating now, is a metastatic adenocarcinoma of the stomach with extrapulmonary tuberculosis. So so this is where the sad part of the story comes in. So we initiated anti-TB and started her on palliative FOLFOX on the 10th of May. Unfortunately, during the 3rd cycle of FOLFOX, she developed renal impairment, acute renal failure, and the patient began to progressively deteriorate. So at this point, we actually had a family conference with the patient and her husband, which was initiated by the oncologist and myself. So patient and family at this point decided to, for hospice care, they refused for any further chemotherapy due to the side effects. Patient unfortunately expired at home on the 17th of July. God bless her soul. So we have learned quite a lot from this, and we would like to get the oncology input, but unfortunately, Dr. Marfwa is not available. She's away with the family emergency. So Dr. Chia will be able to fill in her position. Take it away.
So Dr. Chia Chung Hon, you have the floor.
Okay, thank you very much, Dato, Dr. Anitha, and Mr. So I'm Dr. Chia, and I'll be presenting on a bit from the oncological side. Okay, so as we have already heard the case and the presentation from the other team, so this patient is a young patient and with a primary gastric cancer with terminal ileal metastasis, and unfortunately she had rapid progression with the ascites and also peritoneal metastasis. So in this type of case, so we will go towards a palliative chemotherapy because of her rapid progression and also all the other comorbidities. And then a bit on metastatic gastric cancer. So this type of case is usually diagnosed at advanced stage. The prognosis at this stage would be very poor, and to make matters worse, she had signet ring differentiation, which is less chemosensitive. So in this patient of ours, there are two pathology, as we have already discussed, and these two pathology actually has correlation between each other. So she has cancer on one side and the other side she has TB. So what is our main concern is the burden of the TB in cancer patients. So is it tumor site specific? And the sequencing treatment and its action. So how would all this TB and this cancer, how would it actually affect the outcome and the prognosis? So cancer and tuberculosis is two global health issues. And the incidence is actually continuing to grow. And the risk of TB in this patient particularly, she has immunosuppression from the cancer itself, immunosuppression from anti-cancer treatment, and also the reactivation in cancer patients. So here I have two studies that is talking about the incidence of TB in cancer patients. So one of the study titled Risk of Active Tuberculosis in Patients with Cancer. So it is found that hematological lung and head and also neck cancers have 9-fold higher risk of developing TB. And another paper titled Association Between Tuberculosis Infections and Non-Pulmonary Malignancies. It is found that head and neck, lung, gastrointestinal tract cancers showed higher TB incidence. So there is strong association between lung cancer and pulmonary tuberculosis. And in this, other than that, the other malignancies we reported tuberculosis burden are head and neck, gastrointestinal tract, just like our patient, hematological breast malignancies, and melanomas. So prognosis and outcome for this patient, from one study, the burdens of tuberculosis on patients with malignancy, it is shown that mortality rate during 6 months is about 15.56%. After the diagnosis of TB was higher than that within 6 to 12 months, which is about 5%. The cancer patient with TB had higher all-cause mortality of 20.56% at 12 months, rather than 11.84% in those without TB, indicating that active TB infection correlated with the worst outcome in patients with malignancy. And a previous study have also shown that pre-existing TB is associated with an increased mortality in lung cancer. So anti-cancer treatment and anti-TB, there is no clear guidance in patients having these two pathologies together. However, some literatures have suggested two approaches. More than 60% of the studies have recommended the commencement of anti-TB for 2 to 4 weeks prior to cancer therapy. And on the other hand, there is concomitant therapy of anti-TB and cancer therapy. And from these papers, the toxicities that is commonly reported are liver enzyme derangement. So as in our patient, she was, we followed the first recommendation, which is commencement of anti-TB for 2 to 4 weeks prior to cancer therapy. So back to our case. So in this patient, there are two factors that occurring in her. The first is malignancy. So in malignancy, she had recurrent intestinal obstruction, aggressive disease, and also poor nutritional status. And on the other hand, for TB, she is a refugee, poor economic status, passive smoker. This, in her condition, these two factors are actually in like a vicious cycle. It's both, one is making the other worse, and it's continuously making her outcome and her prognosis very poor. So just a short recap on her treatment throughout this period. She was started on anti-TB and had intestinal obstruction, which was treated conservatively and spontaneously resolved. Then we went to cycle 1 of the FOLFOX chemotherapy. And after giving the FOLFOX, she had severe abdominal pain with diarrhea. But once it was resolved, we were able to start on cycle 2 of a FOLFOX. But unfortunately, we were not able to continue to the third FOLFOX cycle due to intestinal obstruction with worsening renal impairment and also finally hypoalbuminemia. And before I end my slides. So the take-home message for today is TB in cancer patients more common than we think. Active TB can influence mortality, and more commonly, anti-TB is initiated prior to cancer therapy, and so anti-TB and chemotherapy can actually be given without major toxicities. That's all from me. Thank you.
Thank you, Dr. Chia. A little bit more, for this patient, we were not aware of vaccination status. So in Malaysia, we are blessed with a very strict vaccination regime, and that protects many of us. Even if you do get TB, it would not be extensive due to our vaccination. So in this lady, I think unfortunately, sort of like a double whammy. So she had cancer, she had TB, and she did not even have vaccination to begin with. And yes, as Dr. Chia mentioned, the two diseases are contradicting each other in the sense that on one side you have cancer, and the other side you have an infectious situation that causes what do you call that, complications, especially if you're going to start chemotherapy that will further worsen your immunity. So put this together, and it is a very difficult and complex situation for this patient. So yeah, I think that.
Thank you, everyone, for a wonderful presentation on a very interesting case. We'll now go to the audience. Does everyone have, anyone has any questions?
You can type it on the chat room.
Yeah, you can type it on the chat group. Your questions if you are camera shy. Okay. I have a question whilst waiting for the participants to ask them. So in this particular case, what do you think, what is the value of the PET-CT? Either Mr. Guhan, if not our radiologist, Dr. Emilia, could answer this question.
Hi, so PET-CT, I'm not the person to answer about PET-CT because we have our own nuclear medicine center here. But what I know is that PET-CT basically you can detect the hypermetabolic activity of the tumor. For instance, in cases prior to any operation, you can actually do a PET-CT to target it for biopsy for the most highest SUV lesion. And you can also use to follow up patient to see for metastatic deposits of the tumor. So PET-CT will be beneficial for patients management.
But in this particular case, that we already have the HPE diagnosis of underlying malignancy, and both in tuberculosis as well as in malignancy, there's going to be FDG uptake. So in that instance, what's the value of PET-CT in this particular case?
Yeah, I think during that MDT discussion, what we actually came up with was, okay, so we know that this lady is stage 4 to begin with. She already has peritoneal mets, so that says a T4B. So one of the main reasons why we actually initially decided to do the CT was to actually see if there were other metastases. Yes, TB metastasis does not typically light up with PET. That was part of the discussion that we had. So we are going to only see cancer light up. So especially for hypermetabolic lesions like cancer, that's where you really see the FDG uptake. So because of that, we wanted to actually have a look at what's going on in the lungs, because the CT scan already showed that there were no obvious lesions to suggest TB within the lung. So we wanted to know if there were peritoneal mets, have we removed as much as possible in terms of the peritoneal metastasis? And number two, were there actually lesions for us to deal with in the lung? But unfortunately, I think this answer was also kind of became obvious 1 month down the road when she started to develop complex ascites. So this showed that she already had significant peritoneal seedlings beyond what was actually resected in the abdomen itself. Does that answer the question, Miss?
Thank you, Dr. Guhan. Just moving on to the Q&A, we have an anonymous attendee with a question. Did the patient get free medical care because of the TB status? Shall I answer?
Yeah. Miss, please.
So I think to answer your question, yes, TB, they do get free medical care, but she's also got refugee status. So that will be covered as well.
Yes.
Any other questions from the participants? We'll wait another 10 seconds before we move on to the learning points. All right, so it looks like there are no questions because the speakers were also wonderful and everything was explained so beautifully. But just before we wrap up, I'm just going to share a little bit. So ideally, no one is going to think, if someone comes in 32 years old with a short 3-day history, localized right-sided abdominal pain, appendicitis is the first thing that's going to go through everyone's head. And in most centers, patients will not get a CT scan. So we would have opened up and then be stuck with a very difficult situation. So, and also on an X-ray, there were no prominent dilated bowels to begin with to entertain a history of intestinal obstruction. So, well, all I could say is that with experience, and this CPC should bring awareness to how rampant tuberculosis is in our society, with a lot of foreign workers who are unvaccinated, and this should have increased our suspicion because she is a refugee and most likely coming from very overcrowded situations. So hence, in the future, do think about tuberculosis because it's way more common than you think. And doing the CD scan did provide the team with a little bit more information. Hence, when they went in, they did not anastomose. That's a second thing that was done very well in this case, because anastomosing this particular patient would have been disastrous. She would have leaked, and then that would have been one disaster after another. So hence, well done, everybody, and that's all I have to share. Oh, there is more questions. Okay, let's go to that. Where? Yeah, under the Q&A, I've got the same question. Oh, so there are some online questions on Kahoots that will be posted soon. So please proceed to answer those questions.
Okey, ini untuk undergraduate, tolong gunakan nombor matrik anda. Untuk undergraduate quiz ini untuk undergraduate, tolong gunakan nombor matrik anda.